The Wellington Eye Clinic was established in 1980. Since 2006, it has been located at the state-of-the-art Beacon Medical Campus in Sandyford, Dublin, close to the M50 and the Lewis. The clinic has a special interest in laser eye surgery, cataract surgery and keratoconus. This DVD is designed to inform patients about keratoconus and the treatment options available. We are very fortunate to have amongst the staff my partner, Dr. Arthur Cummings, who performed the first corneal cross-linkage procedure in 2007. We regard the treatment of keratoconus at the Wellington Clinic as being a team approach. We are indeed fortunate to have the services of Claire Maguire, who's a very experienced optometrist and has more than 10 years experience of fitting contact lenses for keratoconic patients in Oxford and Birmingham, and now for the last 3 years in Dublin.
Keratoconus is a corneal dystrophy that you're basically born with, but it manifests in your late teens typically. It tends to be progressive. It affects 1 in 1,000 to 1 in 2,000 people. What happens is the cornea becomes more conical and more cone-shaped, and this distorts the vision. So the very first and best option initially is the use of contact lenses to try and improve the shape of the cornea and hence your vision. Keratoconus is typically progressive and would tend to progress in 5 to 7 year cycles. So it's normally diagnosed in your late teens and then gets progressively worse for approximately 7 years, and then is relatively stable for 5 to 7 years, then gets worse again. And this cycle of progression continues until approximately 45 to 50. And at this age we tend not to see further progression.
Niall Corkery, brilliant ball in, he's got away, goal chance! Goal for Bernard Brogan!
I realised that one of my eyes had better eyesight than the other, so that's when I sort of realised that my eyesight wasn't what it used to be. So then I just went to the opticians and they diagnosed me with astigmatism and with keratoconus.
First noticed I had keratoconus would have been about 10 years ago. The prescription of my glasses seemed to fluctuate quite a bit between visits to the optician. So my optician actually suspected that I might have had keratoconus, so he actually sent me to see a consultant just to confirm that the condition was present, and it was.
I first noticed a problem in my eyes in the last couple of years with a general deterioration in conditions like basic things like being able to watch a match on the television or actually being at a match, or a lot of my work involves driving, so going home from work with oncoming traffic. And as a result of that I went to see my local optician, who suspected I may have the condition and referred me to the Wellington Eye Clinic.
So typically the treatment for keratoconus would start off with spectacles and then possibly soft contact lenses, but often the keratoconus gets too advanced and the patient will need RGP contact lenses or rigid contact lenses. How I often explain keratoconus to the patient is it's like looking through a distorted bathroom window, and no matter how strong spectacles they wear, they still can't see through it. How the contact lens works is kind of your cornea is conical shape and the contact lens presses on the cone, smooths the surface, and therefore you can see again.
At the Wellington Eye Clinic we have the full spectrum of treatments available to best manage your keratoconus.
This includes very specialist keratoconus contact lens fitting,
as well as all the surgical options. These include corneal cross-linking, Intacs and SIM-LC. It's the only procedure out there that has the ability to stop the progression of keratoconus and in some cases even improve the keratoconus. Keratoconus is a condition where the corneal fibers are not held together tightly enough, and because the fibers are quite loose, they've got the ability to slide over one another. Many keratoconus sufferers rub their eyes, and the combination of rubbing on the eye and the intraocular pressure allows these fibers to slip over one another and the cone forms. So with cross-linking, if we can first of all just stop the progression, that's already success. And this we achieve in 100% of patients. We slow down the progression. In 95% of patients, we can actually stop the progression completely. And in 70% of patients, we have the ability to improve the corneal shape and hence the vision. At the Wellington Eye Clinic, we think there are two indications for cross-linking. The first one is for the person who's been recently diagnosed. Their condition is progressive, they know it's getting worse, and instead of watching it get worse, we figure it makes a lot of sense to try and stop it getting worse now while the patient still has useful vision. So that's the first indication, would typically be the younger keratoconus patient.
The second indication is in the advanced keratoconus patient, where basically they can't wear their contact lenses anymore, either due to discomfort or because we cannot fit a lens because the cornea shape has got so steep. Hopefully by doing the cross-linking at this stage, it may actually prevent them from needing a corneal transplant because the shape may improve, which will aid contact lens fitting.
So that's quite interesting. You've heard Claire say that doing cross-linking, in fact, makes fitting the contact lens easier in many cases. So the patient might be able to go back to wearing contact lenses again and hence avoid the corneal transplant. In the rare event, however, that corneal transplant is still indicated, at least now you are transplanting the donor cornea into a cross-linked cornea, which is a much stronger cornea, and the recurrence of keratoconus in the new cornea should be greatly reduced because of this cross-linking.
I was referred to the Wellington Eye Clinic and they suggested the corneal cross-linkage. After I did a bit of research myself, I decided that this is probably the best option for me.
After local anaesthetic has been instilled, the surface epithelium of the cornea is gently removed or peeled back, exposing the undersurface. Riboflavin, which is vitamin B2, is then dropped onto the surface of the stroma, and over a period of 20 to 30 minutes it soaks through the stroma like a sponge. Then we switch on the ultraviolet source. It is a combination of the ultraviolet light acting on the riboflavin which releases the high energy bonds which cause the linking of the collagen fibers in the cornea. The ultraviolet light is on for 30 minutes. It's a specific time and a specific energy that allows the process to occur safely without any damage to the interior structures. Once that has proceeded and has finished, the eye is then cleaned and a soft bandage contact lens is inserted. After that, you're free to go home, and you'll be using drops, antibiotic drops, for approximately 7 to 10 days.
So on the day of surgery, I went in, I was in the clinic for about 2 hours, an hour to 2 hours. The procedure itself was completely painless. You're awake during it and you're given a local anaesthetic, and it looks like almost that there's like a pane of glass in front of your eye at which they're putting drops on, so you don't feel anything. It's quite a surreal experience actually, but it's not that bad. Afterwards, there is quite a bit of discomfort for the rest of the day and the day afterwards. But I was given plenty of painkillers to deal with that.
For the left eye, I probably had about 4 hours of pain after the procedure, and probably just a wee little bit the next morning. For the most part, after that, I had no problems at all.
What we hope to achieve with cross-linking is to stop the keratoconus from progressing. This we achieve in 95% of eyes. In the other 5% of eyes, we slow down the progression, but there may still be some progression. In 70% of eyes, we in fact see an improvement in the corneal shape. When we do see an improvement, it is typically 2 or 3 diopters of shape improvement, and we need to have 400 microns of tissue available in order to do cross-linking. We can, for corneas that are thinner than 400 microns, we can swell them preoperatively in order to allow cross-linking to take place.